Hi and welcome to another KangaTech webinar. Today we're joined by Alistair McKenzie, the Head of Science and Medicine at Derbyshire County Cricket Club. Today Alistair is going to be giving us a presentation on a rehabilitation case study that he's used the KT360 as a part of. And without any further ado, I'll bring in Alistair and he can give us a brief background on himself and introduce and crack on with the presentation. Alistair, how are you?
Yeah, very well. Thanks, Jimmy. How are you?
Yeah, very good. Thank you, mate. Looking forward to the presentation. I'll let you get cracking.
Thanks, mate. Okay. Hello, everyone. Thanks for coming and downloading this webinar. My name's Alistair McKenzie, and as James said, I'm the current Head of Science and Medicine at Derbyshire County Cricket Club. And this webinar is part one of a rehabilitation case study following a lumbar bone stress injury in a fast bowler, and how we applied KT360 to our rehab and training. So as I mentioned, I'm a physio based in the UK and had a particular interest in the management of lumbar bone stress injuries just through where my experience has taken me, being in cricket predominantly and academy football, where we see a lot of these injuries and a high burden of these injuries has kind of put me on this trajectory to dig a bit deeper. As I mentioned, the aims of this webinar are to discuss how we apply the KT360 and isometric testing to a rehab framework for the early to mid stages following a lumbar bone stress injury. So what we'll do is try and briefly go through the key elements of lumbar bone stress injuries relative to fast bowlers and this player, look at the function of the spine and how it is utilized in sport, plus and how we need to restore it from a rehab point of view, consider the anatomy, and then from there create some rehab specific goals and go through some applications. Okay, so a lumbar bone stress injury in a fast bowler is probably one of our most highest burden injuries. Similar to ACLs in football, cricket have a large burden with a consistent trend on the contralateral side to a fast bowler's delivering arm. So if you're a right arm fast bowler like this guy, you're more than likely to end up with a primary left-sided pars fracture. In this case, he's 25 years old, which is important from a bone mineral density perspective. He's on the bridge of the first team, and therefore his workloads need to be considered, and his previous medical history is a long-standing history of a left proximal hamstring tendinopathy. His clinical presentation was classic to a bone stress injury: persistent kind of stiffness associated with activity, diffuse and irregular, stiff, and then following a 3 or 4 week post workload ever, gradually worsens until he stops, and then we image and burn the lumbar bone stress injury. Now, spondylolysis is an umbrella term that incorporates a lumbar bone stress injury, and it refers to a fracture through the pars element, this neural arch of the vertebral body. So you have your pars here in between the superior facet and the inferior facets of your lumbar spine predominantly. And when you get a fracture or across there, you then lose the structural integrity of that unit, and you're more like that segment, and you're more likely to end up with further damage or a subsequent fracture on the contralateral side. However, spondylolysis, as it's an umbrella term, incorporates both congenital defects and so on. So we're interested in the lumbar bone stress injuries that have a predominantly bias towards biomechanically load-induced bone damage. As we said, they're high prevalence in adolescents, consistent trend in fast bowlers, and that means that we have to be very sport specific about what we're returning this player to. And with that being said, although we're going to talk about this case study, it is always important just to remember that this N=1 approach to rehab is important. But there are some clinical heuristics that I can put out in the early management phases that help lay the scene of our overall clinical management. The initial assessment being to determine if patient threshold imaging. Initial images, it provides a provisional diagnosis, and we can look at risk factors. We then go through conservative management to let the bone settle in its process. And then when we become pain-free for a consistent period of time on clinical testing, we can then slowly start to consider reloading and re-imaging to go on to the next phase. So that's a heuristic that stays fairly consistent overarching my rehab management. So again, the aim is to look at how can we utilize isometric strength testing and training in the early to mid stages following a lumbar bone stress injury. Now, when we consider the function of the spine as a unit made up of, in a biotensegrity manner, where we can exploit the body to produce, store, and release energy either into the ground or into onto an external object. That is that when we look at the length tension ratios or the length tension curve, we're trying to produce a lot of force into the ground to create some compression tension, to create a lot of energy onto this ball. And if you look when we're bowling, when we add that negative force, the line of force will get to in and around the lumbosacral junction where L5-4, where the predominant has. And then because of that braking force there, it will be created a U-turn into this elastic energy to then whip onto the ball. So we can see why through fast bowling, the left side of the lower lumbar spine gets injured during this phase of the delivery. However, it's also important that beyond the kind of elastic properties of the spine, that it needs to be able to store and produce and transfer energy. It also needs to resist torque. And it does this by perceiving to be still, even though we're accelerating. So during this float phase and acceleration, the trunk is in a nice neutral position, and then there's large shapes around him. And then likewise in other sports. So when we're applying these concepts to other sports, we look for similar trends and how does that influence in and around the spine. Then from a rehab perspective, what we're looking at predominantly is bone healing and the times in which it facilitates this reversal stage, and then formation starts to begin. And normally fractures happen in and around the midway between the activation and the resorption. And it's actually down here where you start to become symptomatic. When they become asymptomatic and you've identified that there's healing on imaging, then you want to try and start thinking about reloading them in an osteogenic way that's going to promote healing. So these little impulse loads, these little blue sections represent little short, sharp bone loads, and how that improves bone turnover compared to a long hold, for example, where you have less bone turnover. So from a rehab perspective and a performance perspective, we're starting to create two kind of ends of the spectrum. So with that in mind, we can start to set out some rehab goals. So with bone healing being in the middle, what we want to think about is how do we create balance in load distribution at that segment during normal locomotive activities. So from a survival perspective, the tissue likes to be loaded in a cyclical manner, where when you're walking, for example, you are switching from one type of organization, switching to another. When you go from left stance to right stance, you're going from two different positions, switching and rotating in cyclical matter. And the spine does this through lordosis, the development of a lordosis during our evolution into upright standing. So it's important to understand that we want to restore lordosis because that's important for energy distribution, and it also exploits the coupled motion of the spine due to the geometry. Over then on the right, we've got restoring the frontal plane. Actually, sorry, correct me there. I'm going to restoring the sagittal plane first. So from a performance point of view, the sagittal plane and specifically extension is the most powerful of all of them. And that's because we're trying to fight the deceleration that gravity is causing us. So we have to have a large extension torque capacity in order to stand up, but also then add energy into that system at the hip and the spine to then accelerate forward and change our velocity. Likewise, we need hip flexion to be able to counter that. So a bit like James Moore talks about sagittal extension, sagittal plane extension is king. It's similar with the spine, in my opinion. Then we look at the horizontal plane or frontal plane, and similarly to James Moore, the adductor abductor comes next. And what we're trying to do is restore the control in the frontal plane. And as you can see in the frontal plane, when we have no real mass other than soft tissue on either side, you can see how the spine would be unstable in that point of view. So we have to be able to control left and right. And again, in an extended posture with a good lordotic spine, and you apply a lateral flexion to the trunk, you'll get a subsequent tertiary axial rotation due to the geometry of the spine, which is one of the most efficient ways of producing from vertical to an axial or horizontal gait locomotion. And then obviously in cricket, we're going to look at restoring extreme control of leptin, but that would be in the later stages. Then when we consider about the wider body and the kinetic chain and the distal elements, essentially I view that as we're trying to influence how well the distal segments clean the impulse load before it gets to the spine. The spine likes nice and predictable loads, but multi-directional and they're time dependent. So it likes a high impulse load. And therefore we're going to try to return them to running first to utilize that impulse load so that we can start to promote bone healing once we've got to that stage. So again, the goal of the early stages is to return to running, or to prepare this athlete for return to running. And that is because we're trying to prepare the bone for the cyclical impulse loads to the posterior elements, especially during stance phase, where you can see that the facets of that stance phase are most interlocked. And then we can use this load to favor bone adaptation. We can understand the kinetics and the kinematics of running, as we can see both here. This is a paper by Sado where they looked at the kinetics around the lumbar, around the spine and the pelvis relative to different increases in running speed, a lot like Anthony Sacchi's and Dawn's papers and so on and stuff like that. Then also with running, we're very, very adapt to monitor workload. And then we can use that benefit from both a bone, a spine, and the muscular health and function element. So that's going to make up the crux of our early phases. Okay, let's look at anatomy. So restoring the lordosis. And if you look in the top left here, this axial MRI, you can see that the spine here, we have the psoas major on either side, this big cylindrical shape. We have the rectus abdominis at the front, a thin sliver of muscle with large lever arms. Likewise, at the back, we have the multifidus and the erector spinae here that counter the psoas major and have a small extension moment, but equally a large amount of tissue resistance to movement, viscoelastic kind of resistance to movement, not just the contractile properties. And it's important here that the psoas major is the only muscle that attaches to directly to the anterior part of the spine. The rest is, tissue until you get to this large rectus abdominis. And then equally, you have the QL on the side. So if we look at the architecture of that, we can see that the multifidus can produce a lot of force, but not over a large range of movement. It uses its viscoelastic properties as well. The erector spinae is an accumulate of longissimus and intercostalis, and it sits together in and around a similar place to the psoas major. And then the QLs here doesn't produce a lot of force, but doesn't change its length much either. And that's actually because it's such a resisting tissue. It resists flexion to the opposite side as it blends into the iliolumbar ligament at L5 below. Then you have the rectus abdominis here, not much force capabilities, small cross-sectional area, and a large moment arm. So it doesn't need a lot to produce a lot of force. Then if we look at the force length curve, we can see here nicely when we talk about balancing in the lordotic curve that the multifidus sits on the ascending limb of the force length curve and the psoas sits on the descending limb. So it contributes primarily in outer range when we're stood up, and the multifidus contributes primarily in inner range when we're stood up. There's that nice balance. So when we're looking at lordosis, we think about the tension in the active and passive tissues creates a compression along the spine that acts accordingly to the direction of the spinal cord, called a follower load. This compression interlocks the geometry of the segments and attempts to maintain the lordosis, which maintains the force length curve so that we can transfer and increase torque strength. The lordosis, so increases dynamic strength for the spine, and at low intensities, it allows for the facilitation of coupled motion without using large amounts of metabolic demand. So if you take away all the muscles and you have the spine standing upright, wouldn't take much force for it to laterally bend one side. And the spine utilizes that to create force and exploit gravity into movement. Now, the psoas major is a bit of debate around its control, or influence on the spine. But if we look at here, we just followed that it creates compression, it creates lordosis, controls lateral flexion to the contralateral side. So if you're laterally flexing this way, you know it's going to get tight. We know that it stabilizes the anterior hip and attaches down here. So as it comes up and around the anterior hip, it creates a fulcrum, but then pins it to here. So when you are in hip extension, you have this large passive resistance to lateral flexion, but also it can promote an extension of the spine. It works in synergy with the QL, especially on the contralateral side, to balance the pelvis. And then again, we're looking at running. So when we look at this bottom part here, which was taken from Dawn's, which is the muscle activation of the iliopsoas during sprinting, similar to this paper of Sado, you can see that there's a secondary peak here at 9 meters per second of almost 6 times body weight of psoas load going through their anterior hip. That coincides with so this is heel strike at 0 and toe off at the point of the descending part of this curve. It happens exactly at the same time as this second extension torque just after. It happens exactly the same time as lateral flexion away from that side occurs. And it happens again at the exact time the axial rotation towards the stance leg occurs. So this 6 times body weight of iliopsoas load is creating this pull or this compression on the spine via the hip to create movement and increase performance. And this is why we need to focus heavily on the psoas major. Okay, when we talk about the sagittal plane and we talk about extension being king followed by flexion, the difficult thing with profiling especially is that we can't separate the lumbar spine from the pelvis, and there's a load of complex mechanisms that contribute to an extension torque during high intensity movements. With that being said, we've spoken about the architecture of the erector group and the flexor group. If we look laterally, we also have this thoracolumbar fascia that encases the erector spinae and multifidus in this tight kind of aponeurosis that then slithers off and attaches to the internal oblique and the transverse abs. So if there's a contraction of the transverse abs and the obliques, it's going to pull this way and push the aponeurosis in, or pull the aponeurosis in. If there's likewise a contraction of the multifidus, or the muscle within that space pushing out, it's going to accelerate and amplify the extension torque. So we can't just simply look at extension flexion in isolation. We have to look at how the lumbar fracture fascia, the latissimus dorsi, the internal oblique, transabs, glute max, QL, all contribute to extension torque. Likewise, when we look at the multifidus and the erectors, there's a direct link through the sacrotuberous ligament to their aponeurosis. So there's also a link between the hamstrings especially. So we already know that the erectors and the closer proximal muscles are working to control lordosis to increase the force length curves of the more powerful extensors, facilitates the transfer, extension, and flexion force across the spine. And we have these multiple mechanisms that we need to consider. Okay, next up is the frontal plane. And this is really important because, like we said, we have that lateral instability of the spine if we take away the tissues. So the muscles we're talking about here are going to be the internal external obliques, the psoas major, the QL, and the lower lats. So if we look at this axial MRI, we can see, similar to the rectus abdominis, these long, thin, overlapping slivers of muscle that have a relatively low physiological cross-sectional area, but a large lever arm. The transabs, again, sit somewhere in the middle, again, slightly inside, having a good lever arm, and the rectus abdominis also being that lower physiological cross-section area, but good length and good lever arm. And when we then think about movements and we think about, okay, if I want to counterbalance this, my internal oblique will work with my contralateral external oblique and they'll almost cancel each other out. Whereas if I want to laterally flex, my internal oblique and external oblique and the transabs will all contract on one side and have a significantly increase in their contribution to lateral flexion on the other side, until essentially the external oblique on the opposite side becomes in resistance. And that shows here in the force length curve, where the internal oblique and external oblique cover the predominantly of the curve. Transabs works primarily in mid-range, and rectus abdominis works slightly in the outer range, which fits our idea. And then we look at axial twisting as well. And the internal oblique and transabs, which connects through the lumbar fascia, will control in mid-range, and the external oblique will get into more resistance when it becomes slightly outer range to return it to that neutral position. So between them, they can cover the majority of the curve. And that, again, if we think about sport and where aberrant loading goes through the spine in that lateral flexion position, you know, fast bowling is easy when you look at it from that way. That's why we need to restore both elements, try and find balance. And then we're talking here about the distal elements, where we know that the impulse load that's transferred distal to proximal is cleaned essentially by the qualities of the tissue between them. So primarily looking at, okay, what are the demands of the soleus, hamstring, vasti in returning to running? And then also, how can we utilize them to get some early load? So essentially, in a post-operative case, for example, you can utilize the connection between the long head of biceps, sacrotuberous ligament, and the multifidus aponeurosis to increase the tension in that area without overloading it neurally. And that might be a nice way to get some lateral force transmission into the tissues post-injury or rehab. And secondly, I know fully well I haven't gone on to the kinematics, but that's for someone else who's much better than me. Okay, so let's get on to our framework for an early stage then. And if we orientate ourselves here, these are our tests for KangaTech that we've utilized so far. Here we have our distal strategies that we're looking at. Here we have our kind of early hip and pelvis that we're evaluating for balance in certain positions. Then we progress the positions in the range into a more mid-range position where they're getting more load. And then we go into these outer and inner ranges where the load is going to slowly transfer slightly higher predominantly. And then we look at the spine. So if you look at this from a time point of view, early to mid, we're going to offload them for a period just to allow the symptoms to settle. We can start quite heavily with loading the distal structures, providing we're not loading it through the spine. So a seated calf, a seated plantar flexion, for example, knee extension, and again, the knee flexion is a nice one to actually get some load early through the tissues, especially post-op. So we're going to profile it, and then we're going to train the deficits accordingly. Then during the time, we might use our clinical kind of tests, or we might use the training modalities of the KangaTech to start early loading and test some symptoms of load and compression in and around that area. Then once we're happy, we might profile it, train the deficits, and review at a later stage. Likewise for hip flexion at 60 and hip extension at 30. Train after a period. You're all good. Profile, train, profile. Let's have a look at you again. And this goes all the way down until we get to the end of our first stage. And that's when we feel comfortable that we can look at evaluating the lumbar spine directly rather than proxy through the pelvis. Okay, so application then. So if we look here, we have to start off. I'm not going to talk about the distal ones because I think they're again, for someone else better than me. I can think of many that can do a better job than that for me, better job than me on that. So we're going to look in and around the pelvis and the link between the pelvis and the spine as a tensegrity structure. Starting at inner range hip flexion at 90, biasing, iliacus and psoas major in that shortened position where we're trying to get a little bit of load, early low level load into the front of the spine. And then looking at, again, this hip extension position in 1990. I like this position because the spine's in a little bit of relative flexion. I can control the hip extension and I can get some proxy at some load transfer into the spine. But ultimately, if you're unable to produce the torques that we need, that, Jane talks about these targets that I'm going to reference as I go. If you can't or produce these forces without compromise through the trunk, then I know that there's probably some system breakdown across those lines. And likewise with the hip. So we're focusing on return to running and starting at the open chain kind of positions where a little bit of spinal flexion. So our criteria then, target bandwidth, this lad's 95 kilos. We want them all to be pain-free. Extension in this 90-90 position, we're aiming for about 80 to 100% body weight, so 76 to 95 kilos. Flexion on this inner range, anywhere between 30 to 50% body weight. And then we want a balance between the front and the back, relatively about 40 to 50% in my opinion. So as we look at the outcome here, we can see that his left hip flexion was 28 kilos, which was lower than what we want it to be. His right hip flexion was 33 kilos, which again is on the lowest element of the scale. And there's a relative asymmetry between them of about 15%. And interestingly, the left hip flexor on the pathological side went into cramp almost instantly when we started to do these positions, these tests. So it became something that we tried to really explore with our training after. Again, the hip extension strength there, 69 kilos, not quite up to our target, but not far off. And then on the right hip extension, 85. So in the middle of kind of our target, about 90% body weight compared to the left side again. So this extension flexion, this hip extension deficit was about 19%. And that's again something that we're going to look to try and improve or just monitor how it changes. So if we monitor that then, and this green is our follow-up at the end of our first stage, the excuse me, there's an improvement generally in the left hip flexion over the right. And there's an improvement again in both hip extension torques. So down here, hip flexion increased from 28 to 35 kilos. So again, just teetering into where we would be comfortable with. And the right side was well within our bandwidth and pushing up. The asymmetry improved down to around 10%, 11%. The left hip extension improved to about 81 kilos and then over body weight on that right side. And that creates this asymmetry between these two, which again is important to consider. So when we ask ourselves, what would this do if it starts running, and what would this do to the load transfer across the spine? If he's got this bias for more hip extension on the right, as he starts to increase his speed and he strides out, there's more chance that that pulls him into a anterior tilt of the pelvis on that right side with a bit more rotation potentially, or it's gonna change the force load from that pelvis to the right at higher intensities. However, at this early stage, are we happy for him to start returning to some moderate speed cyclical loading? And I would be happy providing he's pain free. Then we look at the frontal plane and we use hip abductor and adductor at 30. Target bandwidths again for a 95 kilo, according to James Moore, which we like to use, is around 70% body weight for adduction, 60%, 50 to 60% body weight for abduction. And then we know the balance in the frontal plane is slight adduction increase, so a 1.1 to 1 ratio for a bit of balance. So if we look here, his initial left was slightly down, 47 kilos to 47 kilos to 49 kilos, but below for the adductor and in a good place for the sorry, excuse me there, I've got that the wrong way around. So the left adductor and abductor are generally lower than the right side, with the right adductor being considerably lower than the right abductor group. And it creates this imbalance towards a abduction bias pelvis. And especially when we think about his history of a proximal hamstring tendon issue, we certainly want to look at this left contribution of this left adductor into hip extension and offloading that long head of biceps, which is going to increase the tension on the multifidus and the compression of the lower spine. Okay, so what happened? Okay, so as we can see, the left side increased its adduction by about 11%, so nothing significant. But the left hip abductor increased by 28% and is now sitting in a much higher percentile of what we would consider gold standard. Likewise for the right side, and the left and the right hip adductor got about 17% better. So when we think about this as a balance ratio, there's still this abducted balance, but overall the absolute forces are increasing, but we still need to look at the anterior deficit. And again, how will this influence running when we return to our early stage cyclical loading? How will this contribute to lateral flexion with that right hip abduction in a larger place? And how will that offload or increase the load on the lumbar lateral flexors, which we'll look at later? Okay. Excuse me. Okay, so we're now moving into more mid-range kind of positions for the sagittal plane, and hip flexion and hip extension. Hip flexion in 60, hip extension in this 30 degrees position. Jimmy will kill me for not knowing that. And what we're looking at here is an increase in force output, but also an increase in the load becoming more proximal bias and a bit more onto the posterior aspects of the psoas major, which we'll see shortly. And then this extension position coming into a bit more extension brings into a bit more interplay into the lumbar extensions and that role of stabilizing that hip. So here we can see that the left hip flexion is increased by 25%, The right hip flexion is increased by 35%, and the ratio is slightly increasing. On the left side, the left hip extension, is now increased to 57%, and the right hip extension is increased to 20%. And this was over a period of 2 or 3 weeks tops, 3 or 4 maybe tops. And yes, we tried to steer it in a certain direction, but ultimately we're using KangaTech to get insight around which route his body is taking to distribute the load, and can we enhance it for the stage. So there's relative balance here, right? So we may look to actually load this bilaterally in these mid-range positions, as the load will be more evenly distributed across both posterior elements. So INTP, some isometrics in this position where you're training the extensor mechanism to work against a flexor load, or a hold, for example, where you're trying to decelerate something in front of you. This is where deadlifting comes into play. And some of the dogmas of that, where it might actually be beneficial. Okay. Then we go down another layer and we look at prone hip extension, or hip extension in 0, and we look at lumbar extension on the opposite side. The really interesting thing about this prone hip extension in 0, and I'll come to it in a second, is that the role of the psoas major and the posterior fibers of the psoas major and the QL contract into around 60% of their maximum voluntary contraction during this lumbar extension exercise. So it contracts, squeezes the lumbar spine into its congruency, creates a lordosis, puts the erectors on a good force length curve to produce more force, and we'll see that in an EMG. So I'm still looking at posterior and anterior, and now I'm looking at them combined a little bit more, one limb to bilateral. We don't actually have enough data on this, I believe, to know trends, but it's something that we're going to look into. If we look at the left prone hip extension at 0, he gets about 48 kilos through there, and we're looking in and around, say, 50% body weight, so he's not too far off, but a little bit lower on that left side by about 7% or so. Or sorry, a bit more, maybe 10%. The right prone hip extension, again, is at the higher end of that. So there's relatively good capacities, but there is a difference with the left being lower than the right. And if we think about the image of Brett Lee at the beginning, with that left braced leg, the load going through there, through the left glute max, across that left lumbar spine, that actually probably needs to be a little bit higher than the right in order to decelerate that load. So an interesting food for thought of where we go with the clinical reasoning on this. So we test it and we train it, and we utilize the KangaTech training to train specific areas and specific exposures, using impulse loads, using a bit of chaos on the force trace, trying to get them to bounce the force trace curve coast, or trying to hold it. And we utilize that throughout, as well as then using it to feed into our other exercises where we try and manipulate the same adaptation. Okay, so I'm just going to go down. Then we look at the frontal plane, right? And we're looking at this lateral flexion position, trying to incorporate essentially all of the lateral flexors and a little bit of hip flexion, ideally. And we can link that to the abductors, likewise on the right side. And we know that these are going to be important to control lateral flexion that we see, that we think is the predominant contributor to the compressive element of bone stress. So the left lateral flexors, 69 kilos of loads, 73% of body weight. And then on the right side, 72 kilos, about 76% of body weight. So very good, very strong. Is it strong enough? I'm not sure. It's strong enough to certainly start returning to running. But if we're returning to bowling and we're looking at that large left lateral flexion that we're trying to decelerate the right side, we could argue that actually we want this right side complex of the right lateral flexion and the right abductors to be slightly higher than the left side. However, we want the left side to be able to contribute to the extension and the resistance on the left side of the segment. Okay, again, and we don't really have enough data to know what normative is on these lateral flexion tests, but they do recruit maximal voluntary contraction of all the lateral flexors. It's just, is that enough, and does it incorporate enough of the kinetic chain to have good ecological validity to running and sprinting? What we can do then is look at the adductor aspect, and we can look at the link between the adductor. So if you're looking at this figure 8 and the person's lying down, and this is the front of their pelvis, their pubis, you've got the adductor coming into the pubis, into the internal oblique, into the lateral flexors, back round in this figure of 8 shape, right? So why not look at the adductor to lateral flexor ratio and consider the balance across there and what that'll do during stance phase. So the left flexors we've already got. Then we look at the highest adductor scores, and we can see that there's a large asymmetry, about 28% on the left side and 19% on the right side. So that force being transferred through that sling during stance phase, we could argue that by targeting the adductor group, we could potentially increase the tolerance of that aspect of the trunk. And this is the paper I was talking about, where we look at very similar positions to some of these tests we've done. So I haven't done this one. F is a flexion curl up, hip flexion at 30 degrees, resisted maximal isometric at hip flexion at 30 degrees, then at 90, then the bilateral lumbar extension, then the rotation to the left, rotation to the right, and then lateral flexion, the side curl up crunch that we saw on the previous slide. Here we're looking at psoas major on the transverse aspect. So these are the ones that attach posteriorly to the transverse process. Psoas major, PMV is the vertebral body aspect. QLA is the anterior part, focuses mainly on lateral flexion, and the QLP is the posterior part that works in harmony with the opposite psoas major. Then we got red over here, the erector spinae group, the external and internal obliques. So if we look here, where we started the hip flexion at 90, so relatively low muscular effort to the transverse part, bit higher on the vertebral part, so we can start to dominate load away from that aspect. Then as it comes more mid-range, we get a more equal effect, and the line of pull on there on the vertebrae will change slightly. And then if we look at the extension test, you can see here that the posterior part reaches about 60%, and the anterior part of the psoas major reaches 40. So together it creates 100% kind of its contribution at that stage during that extension. And I believe that's to maintain the lordosis and increase the force length of the erectors. Haven't got onto rotation, that's for part 2, but lateral flexion, again, you can see even higher than extension. Both aspects of the psoas major control that. QL, again, we can look at how it changes with that extension, with a massive difference in the posterior compared to the anterior aspects. And then in the lateral flexion, again, maximal contraction. The erectors here, maximal effort during bilateral extension, lumbar extension, and then near for the oblique and internal oblique, you know, almost 80% maximal isometric EMG in that exact test position. So we can see that if we balance all of these, we know that we've balanced the motor recruitment aspect of the tensioning component of the spine and pelvis, ready to load. Okay, so at the end of that point, then at the end of the second review phase, where we accumulate that information, we see, okay, where is our athlete in comparison to where we wanted to be, to our goals? Have we got good symmetry in the load distribution mechanics to return them to cyclical loading? We then do a workup where we look at repeat imaging is essential to look at the status of the bone trajectory Is it in a place where we can load it to start promoting healing? And then we're going to use that to progressively load it through the way. If you would like to contact me in between or after listening to this webinar, my details are here, and I'm sure you can reach out to James and he can pass them on. But in the near future, we are putting in this content into an athletic spine e-course. So if you do like the ideas that I've discussed and touched on, please feel free to reach out and share your opinion, and then we'll keep eyes posted for future events. But until then, I'm really looking forward to part 2 of this series, where we're looking at the mid to late stage rehab and how we apply KT360 to take them from moderate speed running, sprinting, to ultimately fast bowling and monitoring how they respond to loads. Okay, thank you very much. Cheers.
Thanks a lot, Ali. Really appreciate you doing that. There's an awful lot
Pleasure.
of time and effort and work that's gone into that presentation. That's clear to see. What I really like from it is the level of detail and the sheer comprehension that goes into the justification behind our rehabilitation process, and the subsequent objective markers that you look to set throughout the entire process. It makes so much sense. I probably could have wrote down about 20 questions. I'll go through
You can send them to me.
I'll go through 3 right now, but like Ali said, if anyone's got any questions, feel free to send them in to me, or take Alistair's contact details and get them across to Alistair. I'm sure he'll do his best to answer them. So, love the justification for returning the athlete to running activities and sport-specific movements later down the line. But with this particular case, where do you choose to start implementing a load? I know these early stages of deload can be a bit concerning for people when they're thinking about commencing any kind of return to activity. Obviously, you mentioned utilizing isometric training early on, but what was the kind of justification from moving through low intensity training back to maximal isometric screening? Was there any kind of thought process there that you lent on at all?
Yes, good question. So I would say it comes down to understanding the biology and the stage of the fracture and the load you're going to put on it during those tests and in those test positions. And what's that going to tell you? We need balance between the bone, the compression element of the structure, and the tensioning elements, the soft tissue around. So what we're trying to do is we use imaging to determine the disruption of the compressive element. So the bone's fractured, it's lost its compressive integrity until it recovers. That means, what does that do to the tension element? It either increases the compression so it can pull it down and close it and stabilize it, and that then increases the load. So what we want to know is what directions influence what orientation is the fracture, and what directions are going to improve or compromise the congruency of the fracture. And then it comes down to essentially symptoms and a progressive layer of provocative testing. We bias extension testing for this injury, but I actually think it's on a spectrum of large flexions and large extensions. But a lot of the times they can go and missed in clinical testing. Stalks and all that stuff has quite poor utility. But we need imaging to be detailed, and then we need a progressive structure. So yeah, you can do a stalks pain free. Can you jump off a box and land onto one leg pain free? And are you taking it to a level where you can elicit some symptoms to gauge where you're at? That would be the clinical pathway. But similarly for isometrics, can you put tension through that area and not get any symptoms? And do you have an overlap that with your clinical reasoning for the stage of the healing? And this player did have symptoms. He didn't have back symptoms. He had that left hip flexor cramp, and he also did have a bit of spasm on the right sort of QL and oblique region. And we think that he has this right kind of abductor extension bias, and this left kind of weakness on hip flexor that's going to cause a rotation in that's probably going to cause a little bit of a left rotation of the pelvis, which we want to try and balance out. So it's all just trying to piece it together from a direction as well as an intensity perspective, overlapping it. And that's why the follow-up imaging is important, because when you get that green light to go, you need to go and be as prepared as possible.
Yeah, absolutely. Outside of this case study, obviously you've had the system in situ for a little while now. Are there any of the processes that you've applied here that you also take to the healthy population to look to mitigate similar sorts of injuries?
As in outside of sport, or
no,
healthy players?
Within your population, within
Squad.
cricket, the rest of the squad, have you been putting them through anything at all?
Yeah, definitely. We profile quadrants, and we profile the spine, especially of the fast bowlers. And then my most used on the day-to-day is the training modalities. So, we have proximal hamstring tendinopathies, we have the patella tendinopathies, Achilles tendinopathies that don't cause them to stop playing, but require a very specific load. So we like to utilize those most, whether it's a little primer before they go out, they've got the screen, they've got the feedback. So that's something that I'm really interested in. I want to monitor how the tension across the spine and the pelvis changes over the course of fatigue. So, some pre-post tests that are biased, and looking at, okay, well, you've dropped too much and you haven't recovered it yet. And then it becomes a whole new system of monitoring. Yeah.
You pretty much nicked my last question there. That was going to be my final one. Outside of kind of screening for the entire squad, are we looking in the future to shift our attention towards monitoring to really pick apart specific injuries? And if so, what would you be shooting for? Are you looking to mitigate potential PARS related issues, or are you going broad? Are you going injury specific? Are you going athlete specific? What would you look at?
I think it will be location specific, player specific, as in like back specific, shoulder, ankle, knee. They're all small bubbles within one large bubble of that person. So it'll be individual specific, and then each area might have a different level of risk profiling at a certain time. Fast bowlers, we are worried about lumbar stress fractures. Batters, we might monitor, quad strength. They generally tend to get a lot of patellar issues, or just these overload issues. And then throwing again, monitoring the shoulder and how it responds to load. So with our players, we're going to do something similar, prioritizing the bowlers. And then I guess the other thing, Jimmy, is like in and around research and looking to apply this into other sports and trying to see how we can look at performance and risk strategies in and around the trunk, which is notoriously hard to try and do. So yeah.
Brilliant. Well, we'll leave it there.
Thank you.
Cheers, Jimmy, very, very much for jumping on. And thank you for everyone that's downloaded this and listened to it after the webinar. Please stay tuned, keep a lookout on our social channels for the date for part 2. And hopefully we'll see you all then. Thanks again, Ali.
Cheers.